All right, folks, it is right at 2 o'clock. We want to be thoughtful and respectful to your time, so we'll go ahead and get started here real quickly. Let's perhaps start with introductions, and since I'm talking right now, I can start off. My name is Matthew Scholl, and I am one of the emergency medicine and EMS physicians here at Maine Medical Center, Portland. We're going to do this a little differently and do this as a team, Eric and I. So I'm going to turn it over to Eric for his introductions as well.
Hi, my name is Eric Bowman. I am the EMS manager here. Been a paramedic for many years. Went to longstanding EMS educator. So I'm here to help Matt.
So we're going to, like I said, do this a little bit differently. It's going to be a little bit more of a conversational presentation where Eric and I are both contributing. We are in a webinar mode of Teams right now, which means that your cameras are turned off, and I think your microphones are turned off in this mode. So please feel free to use the Q&A or the chat functions. Those will be the ways to ask questions, etc. We do not have any financial disclosures, Eric and I. I think it's also fair to say, though, that there are a couple other things that we need to disclose. Namely, we're talking today about measles. Measles is a disease process that was officially declared eradicated in the year 2000 after a pretty active vaccination campaign worldwide. And because of that, interestingly, Eric and I don't have a lot of clinical experience with this. So we are using our foundational understanding, knowledge of science and medicine, and a lot of different resources to bring this information to you today. We're also using experience from colleagues and others who have treated patients with measles either in the US or outside of the continental US. Now, in an effort to be completely transparent, keep your phones ready. We are wanting to share with you the resources we used to understand measles, and we want to not only give you some of the knowledge or pass on some of the knowledge that we've learned, but we also think it's vital for you to have some of the wisdom or the learning behind that. And so throughout this presentation, there'll be a lot of QR codes for you to kind of snap at and download or have available for you some of that same information. And then at the very end will be kind of a summary slide with some of those QR codes all combined together. So keep your phones handy. Eric, you want to run us through our objectives today and kind of what we're aiming to do?
Excellent. Yeah, today we're going to go over what measles is. We're going to talk about its symptoms and how we move it from place to place and what kind of complications come from it. We're going to ultimately talk about what to do, how to identify a patient that has measles. And we're also going to talk about the basics of it, the common signs, symptoms, risk factors that go with it. Ultimately, we'll move on to explain how this disease actually spreads, as it is one of the more readily transmissible viruses out there, and then how we can prevent it from moving. Finally, we'll discuss some of the best practices for safety in transporting the patients with measles, how to communicate with the hospitals, and how best to ensure that we limit the spread when we're in this process. Back to you.
Awesome. Yeah. So, and maybe we should just take a step back and ask ourselves, why exactly are we even talking about this? If I mentioned earlier, measles was eradicated in the year 2000, what is going on now? Well, I came across this quote from Louis Pasteur. You'll remember him as a French scientist and physician who came up with the germ theory idea. His specific quote in French, translated to English, says something to the effect of chance favors the prepared mind. We've kind of taken that, and a couple other folks across the world have been attributed this, and it has bubbled down to fate favors the prepared. And the reality is, right now we are witnessing a outbreak of measles in the Southwest, and that outbreak has led to the first 2 deaths in over a decade. And then we're also seeing activity across the U.S. as a whole. And the events that occurred initially in Texas and spread to New Mexico have since spread to Kansas, Oklahoma. There's some thoughts that it spread to Pennsylvania, as we'll talk about in a bit. And again, under the mantra of fate favors the prepared, we wanted to start thinking about this. And we've been talking about this at the other levels. We've witnessed clinical bulletins being sent out about this. There's been a lot of discussion. We thought it'd be worth this forum bringing it here and having a larger conversation about it. If we take a historical perspective around measles, it was first described in the 7th century by a physician in Baghdad. This gentleman Razes on the left of your screen is that physician, and he was the first physician to describe measles and define what it was in comparison actually to smallpox. Throughout the Middle Ages, there were lots of different outbreaks, epidemics. It was relatively endemic, and the difference between endemic and epidemic, endemic means that there's baseline disease in the community. Epidemic means an abrupt rise in the baseline numbers of cases in the community. And pandemic means a exponential growth of a disease in the community. So we saw increasing burdens of diseases throughout the 19th and 20th century. In the 1800s, a doctor named Koplik defined some of the pathognomonic findings of measles. And then later on in the mid 1900s, some of the more grave complications of measles were discovered and identified, including something we'll talk about later on called subacute sclerosing panencephalitis. In a 1914 study out of England, they reported an average mortality of about 1%, but that was different. That was the average. And if you look at any given country, the range there was 0.35 in Scotland all the way up to 10%. I believe that 10% was in Peru. So any given country had a pretty big impact of around measles. And then in the years before vaccination, measles actually caused 30 million cases per year and resulted in about 2 million deaths. And what's interesting about that number, 2 million deaths, if you look at the number 2 million deaths per year, and you think about some other public health concerns that we've had in the last couple years to decades, specifically around substance use disorder or alcohol use disorder, and if you look at today's numbers, we see just over 2 million cases of alcoholism and about 300,000 cases of substance use disorder. Just to kind of park that in your brain as thinking about how much of an impact this was before vaccination. And then just thinking about the success of the vaccination program, being able to eliminate all of those deaths, in large part, the vast majority of those deaths with one public health campaign starts to paint a picture of just how grave, how severe, how impactful measles was in those eras, but also just the successes of public health worldwide working to improve outcomes and to decrease the incidence of measles. Now, one of the things about measles to keep in the back of your mind is that this is a burden of disease that isn't necessarily equally represented across all age groups, and children in particular are much more affected. And so these 2 million case deaths per year, this 2 million fatalities were disproportionately involving kids. And even today in developing countries, measles ends up being a major cause of death in children. Now, Eric and I were thinking to ourselves about measles and trying to understand just how bad, quote unquote, bad measles is. And one way we came up with doing that is looking at the relative mortality of measles compared to a lot of other various diseases. And if you think to yourself back to the COVID days, we kind of went through this exercise of this, like how many patients who contract the disease end up getting admitted, how many patients who contract the disease end up dying from the disease. And if you remember early in COVID, we were throwing around numbers in the 2 to 4%, but over the course of our experience with COVID and as we've gotten better treating it, it's evened out to be about 1.1%. Now, that's a very new, novel infection for us. If we compare that to something like influenza that we've been um, dealing with and managing for a longer time, influenza has a case mortality rate of about 0.01%. So COVID is still to this day has a higher mortality rate than influenza. But measles is kind of parked in between at 0.2% or about 20 times more fatal than influenza. To further conceptualize that, if we looked at all folks with pneumonia, the fatality rate of all folks with pneumonia is about 0.01%, similar to influenza. Chickenpox is off the scales, it's less than 0.0001%. But then if we think about all cases, all heart disease patient, everything from the STEMI and out of hospital cardiac arrest all the way to the stable angina patients, so we take all those folks and look at their mortality per 100,000 patients, it's actually less than measles, as is all forms of cancer. The mortality per 100,000 patients in measles is slightly above both of those entities. And as Eric and I were thinking about this and kind of working through this in our mind, wondering about how bad is it, what's the impact, these numbers kind of help us understand just how impactful measles can be, but also historically just how dangerous it's been to the population. Now, I referenced vaccination earlier on, and the reality is that our vaccination campaign against measles has been wildly successful. There's an estimated more than 90 million lives saved since this was implemented in the 1960s. Remember, it was first implemented in the US and it took time to percolate across the entire world and to actually get enough penetration across the world to be able to declare it eradicated in the year 2000 in the US. It's also really safe. There is a incidence of fever and rash after the vaccine. There's a slightly higher incidence of febrile seizures, which are generally considered benign in the vast majority of the population. About a quarter of folks get some degree of myalgias or malaise, joint pains, muscle aches, etc. And there are very rare cases of more serious complications. But if you look at those, the incidence to those other complications is so much higher than the mortality of measles that in general, measles is considered a very safe vaccine. And there is no active evidence that shows any link to creating, causing, or even association with autism. And so overall, this vaccine has been really, really safe, effective, and beneficial to the world population. So we referenced this event that's ongoing in Texas. We referenced a little bit about it sort of occurring elsewhere throughout the country. And if you think about it, take the long view and look back all the way to 1960 when the vaccines were first introduced in the early 60s, you'll see that in general, the case numbers in the US have plummeted from the 500,000 range down to what looks like pretty negligible. Taking a little bit of a shorter view and looking from 2000 forward to, from when we declared this eradicated till now, there have been cases of measles throughout the US on almost an annual basis. The vast majority, if not all of those, actually have originated from foreign travel and exposure of either undervaccinated or unvaccinated US citizens to measles in a foreign country that then just comes back to the US. The event that we're seeing unfold right now in Texas ends up being the largest single outbreak in the U.S., rivaled only by an event that occurred in 2019 in an Orthodox Jewish community outside of New York City. There were more annual cases that year, but the single event in Texas is larger than the single event in measles in New York City, and that just started occurring in the last couple of weeks as we got more numbers reported out to us. So from an annual basis, we're now at the second most number of cases since 2000, rivaled again only by that 2019 experience. And then I think the other reason why this is becoming a focal point of conversation around the US as a whole is that we're seeing a tremendous amount of federal restructuring involving the public health system. We're seeing changes in funding and support both at the federal, state, and local levels. And that all just leads to a significant amount of uncertainty regarding what the response to this event is going to look like, recognizing that our public health system is a pretty tightly woven matrix of federal, state, and local support. And any disruption in that can lead to uncertainty regarding how a response is going to play out. And I think that adds to the complexities of this event right now. More details about this event are, I think, helpful to understand and consider why this becomes important. One thing to recognize is that the CDC is reporting out on a weekly basis. They historically were putting out their new numbers on Fridays. I believe they might have bumped that up earlier in the week. These numbers that I'm showing you are up to date as of, I believe, Friday of last week. So they're the most recent numbers we have. This graphic and some of the QR codes come from a different source, which is a media article, which has done a very good job graphically demonstrating this event. But as of the last data delivery, we had 916 cases that were confirmed or highly suspicious for measles. About 90% of those were occurring due to outbreaks. And an outbreak is defined as three or more cases that are all linked. So I get it, I get the disease, Eric gets the disease, and someone else in our office gets the disease, and it's all epidemiologically linked to my first case. That's what defines an outbreak for the CDC. This event occurred first in Texas in an under-vaccinated community that usually eschews engagement with the medical and the healthcare system at large. I don't know that it's necessarily a specific anti-vaccination approach versus a anti-modern medicine approach. But this event started in Texas and then is spread to New Mexico, Oklahoma, Kansas, and there are even cases as far away as Pennsylvania that are linked to that event. The dramatic thing is that there have been two deaths associated with this, which, if you look at the numbers we'll talk about in a bit, which, there is estimated 1 to 3 deaths per 100,000 per 1,000 cases. That is not unexpected, but that does not dull the tragedy of these occurring in two school-aged children who passed away in Texas. There's a third death, which is suspected but not confirmed, measles related, that occurred in an adult in New Mexico as well. Breaking this down at the state level, Texas, Oklahoma, New Mexico, and Kansas are all linked again. You see the specifics there with the vast majority of cases occurring in Texas, but all combined, that event ends up being the largest event we've seen since 2000, and maybe even stretching back further than that. Ohio, Indiana, there's some cases in Michigan, there have been cases in New Jersey. Those have not been associated with the first events in Texas, although there are some cases out of Pennsylvania that have been linked to those. The Ohio, Indiana, New Jersey, Michigan cases, other cases that you might hear about in the Pacific Northwest, those have been related to some of the background vulnerabilities that I demonstrated earlier. Those are under or unvaccinated people returning from foreign countries where measles is either endemic or epidemic at this very moment. But at least one or two of the cases in Pennsylvania seem to be related to the original event that's occurring in Texas right now. I've
Matt, I
referenced, yeah,
recall
but
our friends to the north are having a bit
oh,
of
you're
a
right,
trouble
Eric.
with
Absolutely.
measles also.
Quebec is also experiencing an outbreak that also is not related to Texas. That's also linked to international travel as well. Thanks for that reminder. So this is an interesting. So again, I've referenced this 2019 event in New York City a number of times, and Eric and I were thinking it might be interesting to learn what can we take from that for lessons. And there are a couple lessons we thought we'd share or we could reflect on. But first, this actually ended up occurring in a community that had a low vaccination rate. Started with a young child who returned from international travel and was exposed to measles while traveling. The child came home, contracted the disease, and that led to about 650 cases across the greater New York area. Um, as far as sort of the duration of that event lasted for about a year. It took almost a year for the public health system to contain the event. And that in part has to do with some factors we'll talk about later, including how transmissible, how contagious measles is. And I think the bottom line is it took a while. So it started in September. The last case was reported in August. But the end of an epidemic or endemic or event, an outbreak, is only considered 2 incubation periods after the last reported case. So even though the last reported case was in August, the event was actually declared ended in mid-September to extend out to 2 incubation periods. So I think lesson number one looking at this event and other events, it takes some time to resolve a measles outbreak. And if we look at a different timelines of the New York City event here spread out, started on October 6th, 2018, extended through September 7th, 2019. That took about a year to resolve completely, just under a year, 11 months. The peak of the event occurred between the 6 to 8 month time frame, just about here. If you look at what we're dealing with in the 2005 Southwest and Beyond event, it started in the first weeks of January, and we should expect a peak 6 to 8 months later, which would bring our peak somewhere in the June to August timeframe, to be quite honest with you. And this could last for about a year. And that's what we've heard from public health experts across the US, to expect this to last for a while. And so lesson number one is these don't go away quickly. They take a while to resolve. Lesson number two is that there's a disproportionate impact on the young. So if we look here at the New York City event, 81% of the patients impacted by that got the disease were under the age of 20. And then if we look at the 2025 event, about 68% are under the age of 19. So close, not exactly the same, but fairly close. There are a lot of reasons for that. Namely, there is some inherent immunization for the oldest of folks who could have even had the disease prior to the vaccine being implemented. The next generation of U.S. citizens existed in an era where vaccination was much more accepted and acceptable, and so there's some inherent immunity there. And as we've seen speculation about vaccines progress, it's usually the younger who have been less vaccinated. And that brings us to lesson number three, that the mortality and the incidence of measles really is also disproportionately impacting those who are or under vaccinated. So to be not vaccinated is very dangerous around a measles outbreak. So in the 2025 event, it's even more dramatic. In about 97% of the cases that have been unvaccinated, or folks who can't confirm or can't state when they were vaccinated. Now, in 2019, we saw serious complications occurring in about 5.7% of those impacted, and hospitalizations occurring about 7.5%, with about 40% of those who were hospitalized requiring ICU level care. We don't have the same granular data yet from the current event, but what we do know is that about 11% of the folks in the current outbreaks are requiring hospitalization. We don't have just yet much data on complications or hospitalization into an ICU. So that is kind of why we're here, the background of these events and what's going on right now. Eric and I thought we would pivot and talk next about some of the clinical facts around measles and what makes measles so unique and interesting. Measles is a virus. It's also known as rubeola. It's an RNA virus. It's part of a family of viruses that includes mumps, parainfluenza, RSV. Measles is interesting because it's got two receptors on its surface, and I just thought this was interesting personally because one of those receptors is called an H receptor. It stands for hemagglutinin. Um, Most of you have heard about things like H1N1, H5N1, all those other types of influenza that are out there. The H in H1N1 is the same H in measles. That H, that hemagglutinin protein, is actually what binds the virus to its cell of target cell. And in the case of measles and influenza, that's commonly an epithelial cell. The F protein helps the virus be assimilated into the cell and lets the virus get into the cell, where it opens up its RNA structure and hijacks the cell's processes to develop more RNAs and more viruses within the cell. In the grand scheme of things, measles is on the smaller side. It's not as small as parvovirus, which is 20 nanometers. It's closer to that of HIV or even SARS at 150 nanometers, but it's much smaller than Ebola virus, variola virus, and it's smaller than even herpes virus. So it's a smaller size agent, which allows it to be um, basically suspended in the air and airborne as a particle, which just impacts its transmissibility and how it gets spread throughout the community. It is highly infective, and there's a couple different reasons for that. The airborne nature, the aggressiveness of that H protein on the cell, and just the number of virus particles that get delivered by a cough or a sneeze. All of those things contribute to the infectivity of measles. If we think back again to our experience with COVID, we were reflecting on something called the R naught. And if you remember back then, that stood for the average number of unvaccinated people that a disease is expected to infect if you are exposed to it. And so we know measles is one of the most infectious viruses known with an R naught of 18, meaning that if I have the disease and I expose a bunch of people, I would be expected to expose and infect up to 18 non-vaccinated people if I had the disease. Another way to think about this is that 90% of unvaccinated individuals who come into contact with a measles patient will become infected. It is a very, very infectious agent. And that, again, there are a lot of reasons for that. It's the small size of the virus, it's the aggressiveness of that H protein, it's the number of viruses that get shed during coughing, sneezing, it's the persistence on surfaces and its ability to float in the air for a period of time after being coughed or sneezed out of the infected person's upper airway or lower airways. All of those lead to that high R naught. The timeline of measles is also tricky because you get exposed on day 0 and it takes about 10 to 14 days to incubate inside the person. You start having symptoms after 10 to 14 days of incubation. And those first symptoms that really start up are fevers. The thing to know about those fevers is they're typically pretty high. The history teaches us that they're usually over 102 degrees and maybe even as high as 105 degrees. They're not always super responsive to antipyretics. It doesn't mean we shouldn't try to give Tylenol or ibuprofen to reduce the fever, but they don't always respond to those meds. After the fever and what we call malaise or myalgias, which mean aches, pains, and the feeling of just not feeling good, after that occurs, the prodromal symptoms start, and that's cough, conjunctivitis, and coryza, what you might hear people refer to as the three C's. I think, honestly, we missed an opportunity here to say cough, conjunctivitis, and nasal congestion. That would also be three C's. Coryza is not a term that I use on a regular basis. It basically means a stuffy nose, so you can sub congestion in there for coryza. It makes it easier for all of us. That fever and the three C's go on for about 3 to 4 days, somewhere in there close to the 3 day mark, maybe the 2 day mark, but definitely by the 4 day mark, something called an ananthem, which is a rash on the mucous membrane occurs. I'll talk more about that in a second. And around the fourth day, a very typical rash develops. That's the exanthem, and I'll talk more about that as well. The key thing to know is that you're most infectious 4 days before and 4 days after the rash. And so people can have these relatively non-specific symptoms of fever, feeling crappy, a little bit of a dry cough, conjunctivitis, and this congestion. And they may not know they have measles. They may not feel horrible initially. Some folks might still commingle with others, mistaking these symptoms as a cold and inadvertently exposing other folks to the measles virus. Right. So this
Matt,
ananthem, yeah, bud.
just a curiosity here. I mean, that sounds like a lot of patients that come in contact with healthcare, like cough,
Sure does, doesn't it?
conjunctivitis. I
Fever,
mean,
cough, feeling bad. That also sounds
rashes.
similar to what COVID presents like. It sounds similar to what RSV is like. It sounds similar to what influenza is like. In fact, influenza, the classic description is abrupt onset of fevers, lots of myalgias, malaise, non-productive cough, etc. This is a very common presentation for a number of really bad respiratory infections, and we're going to touch on that in a bit because I think if we pay attention to that symptom set and we heed caution around that symptom set, we can actually set ourselves up for success around protecting ourselves, patients, and others too. So thanks for pointing that out, Eric. Now, all ananthem means is it means a rash on the mucous membranes, and there's this thing called Koplik spots that are pretty pathognomonic, or meaning a very sensitive for measles. And those are these little tiny bumps that exist on the inside of the mouth, typically described as just lateral to the second molars, and they're classically described as white grains of sand on a red base. This is maybe one reason to examine inside a person's mouth, although I would only do so once you've assumed full respiratory precautions and eye protection, just to protect yourself against exposure to their respiratory droplets. This will occur before the onset of a rash, but it's very transient, so don't necessarily rule out measles if you don't see it. The rash I mentioned earlier develops usually about 2 to 4 days after the prodrome, definitely by day 4. It starts on the face and it extends distally. So face, then head, then upper extremities, torso, trunk, abdomen, and lower extremities. And that spread of disease is pretty common for measles. It's described as a maculopapular rash, meaning it's typically small blotches. Some of those are raised, some of those are flat. It will blanch early on. It doesn't blanch later on. You can't necessarily use blanching as indicative of it. And again, this classic spread and appearance of the rash is also pathognomonic for measles in either endemic settings or epidemic settings. This just is another reminder of all the symptoms: fever, malaise, cough. The cough is non-productive usually. The congestion and rhinorrhea. You can vacillate between the two, and then conjunctivitis. And this is more of a runny, itchy red eye than a goopy, sort of purulent looking discharge to the eye. One of the other reasons why measles is of concern is there's a lot of complications, and I'm sorry for the busy slide here, but some of those complications seem kind of routine, like otitis media being the most common complication we see. Although even otitis media can be meaningful because it can lead to permanent hearing loss. Pneumonia ends up being the most common severe complication and accounts for the most deaths from measles. And that's in part related to the fact that not only is there pulmonary damage from the measles itself, but measles is actually an interesting virus in that it causes immune system stunting in the days, weeks to months after the infection, and that can lead to co-infections with other bacteria or even viral processes. Laryngeotracheal bronchitis, also known as measles croup, is just focal edema of the upper airway that causes lots of death in hospitalized children, usually under the age of 2. GI complications can exacerbate underlying dehydration that occurs from high fevers, etc. There are CNS complications. Those are pretty rare. About 1% of folks will have seizures. Meningitis can occur. Encephalitis can occur. That ends up being one of the leading causes of death in adults. And then there are these kind of longer term complications like the post-infection encephalomyelitis, which is a demyelinating autoimmune disease that occurs weeks after the rash goes away, and it's commonly fatal when it occurs. And another really scary fatal disease is called subacute sclerosing panencephalitis, which is a degenerative neurologic disease occurring years out from the original disease. And there are really tragic stories about especially young kids who make it through a complicated measles infection only a decade later to succumb to this complication called subacute sclerosing panencephalitis. So those are some of the complications, and one more reason why this is dangerous. The diagnosis is a little bit challenging in settings where the disease isn't going on in the background and there's not an outbreak or epidemic. And it's challenging because the symptoms of measles, as Eric pointed out to us earlier on, are very similar to the symptoms of the cold, the symptoms of COVID, flu, RSV, a number of other symptoms. Measles presents early on, like a lot of other things, and so that makes the diagnosis clinically sometimes challenging, especially in non-endemic, non-epidemic settings. Koplik spots and the rash make the diagnosis much easier, but outside of an area where there's lots of disease going on, those in and of themselves may not be enough to make the diagnosis. And so in a non-endemic, non-epidemic setting, diagnosis is confirmed by testing. There are a lot of different options here, including PCR, ELISA tests. There's also there's also isolation of virus media and culture. We're currently doing swabs if we're testing for measles, and those get sent out to either Heddle at the main state Heddle lab or out of state. Now,
Matt, how long does it take for those to come back?
days.
Days.
Yeah, so it takes days before those come back to give us a confirmatory value. And we can't talk about treatment without reflecting on prevention, because the best treatment is actually preventing infection to begin with, right? And we can't talk about prevention without talking about vaccination, appropriate PPE, and strict adherence to isolation once concerned for infection with measles. There are two different vaccines out there. There's the MMR, which we've all heard about, measles, mumps, rubella. There's also the MMRV, which adds varicella to that group of viruses. One dose of those vaccinations is pretty effective at cutting down on infection, about 93% effective. In the 1980s, the US public health system suggested or recommended a second dose, which bumps your effectiveness up to 97%. But remember, there's still that 7% of folks in the one dose cohort and 3% of folks in the two dose cohort that will still get the disease. That can be because they didn't respond, they had an incomplete response to the vaccination. It could be because they were exposed to such a very high viral load. The good news, though, is that in the vaccinated population, the disease impact is ameliorated greatly by undergoing vaccination. So there, even though you may still get the disease in that very small number of folks, the impact of the disease will be less than it would have been otherwise. Now, prevention is key, and that again we'll talk about this a little bit more, but there's a multi-pronged approach to prevention. It's vaccination, it's still personal protection, it's all the other infection prevention measures. There's no real medicine, though, for measles otherwise. There's no antiviral for measles per se. We'll talk about prophylaxis after exposure in a bit, but really the mainstay of treatment for measles is supportive measures, addressing the known impact of measles. So that could be everything from fever control, hydrating the dehydrated patient, supportive care otherwise is important. We heard a lot about vitamin A in the news. We've heard that vitamin A may be a treatment, vitamin A may be preventive. And I think it's important to be thoughtful about the value of vitamin A. There is evidence that it really seems to help, especially in populations in developing countries that might be malnourished. So there is some evidence that a person who doesn't have adequate stores of vitamin A could benefit and may have a decreased mortality when using scheduled doses of vitamin A after diagnosis with measles. That's been extrapolated by the American Academy of Pediatrics to be used in all pediatric patients in the general population. It's not a treatment, meaning it doesn't make the virus go away, but it may lessen the symptoms and the complications of measles. And that's why the AAP has recommended it. It does not prevent diseases. And unfortunately, the other thing we know about vitamin A is that used in extra large doses or used sort of at too high a dose, it can actually cause problems. Everything from nausea, vomiting, headache, joint pain, muscle pain, visual problems, all the way up to things like liver damage, increased ICP, and even coma or severe neurologic problems. This QR code links to the AAP statement on this and also gives an understanding of what the recommended dosing scheme is. I mentioned earlier that the unvaccinated or the undervaccinated can undergo prophylaxis. That could either be a dose of the MMR vaccine within 72 hours of exposure or a dose of measles immunoglobulin within 6 days of exposure. So those are the two options for folks who are either unvaccinated or undervaccinated should they come into contact with a patient who has measles. Now, one thing to recognize is that similar to COVID, not when we first saw and experienced COVID, we expected a high hospitalization rate, but we also knew that a good portion of those folks wouldn't initially require hospitalization. The same is true for measles. Not all patients who have measles will need to be admitted to the hospital. There might be some folks who get admitted for dehydration. There might be some folks who get admitted for respiratory failure or distress or concerns. There might be some folks who get admitted because of social reasons. They can't isolate appropriately. At this moment right now, the admission rate in Texas is 11%. And in that earlier event in New York, the admission rate was about 7.5%. So patients can be discharged. They get discharged from the hospital with return precautions, meaning that they are told if you can't hold down volume, if you're having profuse diarrhea, if you're getting dizzy when you stand, if you're very short of breath, if your symptoms worsen, come back. And this sets up one of the potential means by which we, as EMS clinicians, might be exposed or come into contact with these folks. So that gets us to this idea of how do we spot measles in the crowd? Between me and you guys, Eric was pretty clever, or felt himself very clever by coming up with this pun here, spotting measles in the crowd. I'm going to give him full credit for that pun. Now, the question becomes again, how might I come into contact with a measles patient? And I think there's at least three different scenarios. And so scenario number one is the previously undiagnosed patients who have a prodromal or identifying symptoms of measles. Possible exposure number two is a previously diagnosed person who is isolating and develops complications and calls 911 for those complications. And then scenario number three comes down to the interfacility transport of a known or a suspected patient. And we put a little asterisk on this slide to remind ourselves that in Maine, there are few hospitals that admit pediatric patients. And pediatric patients, as we learned earlier, are disproportionately impacted by measles. And therefore, if a patient who is young and needs admission arrives at a hospital that doesn't have that capability, there's a large chance that we as the EMS system will be leaned on to move them to the place they need to be. And so that just increases the possibility of that paradigm as well. So let's talk about this first patient, this previously undiagnosed with prodromal or identifying symptoms. We talked earlier about the prodromal symptoms, fever, cough, congestion or coryza and conjunctivitis, plus Koplik spots and or the pathognomonic rash. And in a New England Journal of Medicine article that I'll give you a QR code later on, the authors reflected on the CDC's case diagnosis, which includes those things in an area where there is there's endemic or epidemic activity, but in a low positive predictive value setting, a low incidence setting. That also means we need to test to confirm our suspicion. So laboratory confirmation becomes very, very important in that person. But the clinical diagnosis can help us. Um, However, it's most helpful if there's lots of activity in the background. So this is my contribution to the punny offerings of this lecture, which for those of you who are not born or not alive in the 1980s, I feel sorry for you because you never got a chance to hear the musical, whimsical nature of Whitney Houston, but she had her first breakout song, How Will I Know? So, how will I know that this person has measles? Well, a couple different things here, right? So, in the latter two things, patients with worsening complications or if patients will have a high clinical suspicion by history. The patient who has worsening symptoms will tell us, hey, I was just seen at the hospital. I was diagnosed with measles and now I can't hold down fluids. The patient who is being moved between facilities, that should be part of the facility's report out to us. We are highly clinically concerned that this person has measles, or we have confirmed that they have measles. That will be occurring. In the patients without previous diagnostic uh, without previous diagnostic confirmation, the novel patient coming off the street, we need to consider the common symptoms and the pathognomonic symptoms. So the cough, coryza, conjunctivitis, fever, the rash, the Koplik spots, etc. Now, to get even a little bit further down the line, you can add on a travel history, and the travel history is actually interesting. These are the countries with measles cases in 2022. Notice the number of cases that occurred in Asia and Africa. Also, large number of cases in developing countries. So that's another way you can get there. But it may be really difficult to confirm the diagnosis if not previously diagnosed. And so I think it's really important for us to have a high level of suspicion and don appropriate PPE. That becomes essential for our safety and other safety. And that gets us to the next section, which is how do we stop the spread?
Matt,
So,
you
yeah,
made me think of a question while we were there for a second. So if I arrive to a person's home and they have these signs and symptoms, but they're not truly distressed, but they want to go to the hospital, what do I do? Do I just take them to the hospital, or do I, say, hey, maybe it's better for you to stay home?
Yeah, so great question, Eric. I think what you're reflecting on is some of the practices that we initiated in the COVID pandemic, where we actually deferred transport of folks who had minimal symptoms. Please remember that that was a protocol that was enacted and then retracted, and it was enacted in anticipation of large volume surge on the healthcare system in an effort to decrease the impact on hospitals. And that effort was also supported by a lot of conservative practices to maintain a awareness of the individual's ongoing status. We gave a lot of resources to the person specific to COVID, et cetera. We're not there yet here, right? And so we wouldn't necessarily have an EMS initiated non-transfer of a patient like this. We Who knows? We might get to that if the numbers start to really, really climb, if this becomes really onerous on either us or the healthcare system. We might find ourselves in that setting again, but right now we're not there. So that's not necessarily something we either should or could be doing. The other thing is that when we were enacting that around COVID, or when we talked about enacting that in pandemic influenza, those are in environments where there is expected to be a very, very high incidence of the disease in question. Right now, we do not have a high incidence of the disease in question. And so telling that person that they shouldn't be transported may actually thwart them from having diagnostics that define exactly what their underlying disease process is. And there might be therapies that could help them. So, for instance, Eric, that person may not be suffering from measles who has fever and a cough. They might be suffering from COVID and they might benefit from an antiviral agent. They might be suffering from some type of bacterial pneumonia and benefit from a antibiotic. There are lots of different possibilities in a non-endemic, non-epidemic, non-pandemic setting, and so we should transfer those folks for more diagnostics. Great question, though. All right, back to stopping the spread. So I pulled up this photo to remind us. We all saw a lot of this kind of Swiss cheese model of disease spread during the COVID pandemic, recognizing that there are lots of different steps to try to prevent disease propagation. Everything from distancing to masking to hand hygiene, avoiding touching your face, which is, as I just rub my chin, I recognize is harder than we all want it to be. um, Limit your time in crowds, stay outdoors and ventilate, sensitive testing that's really, really quick and turnover, adequate and widespread messaging, quarantine and isolation, and then finally leading to vaccines. And I think we have to really remind ourselves of that model and remember that it's not one thing that stops the disease from you from getting the disease. And in fact, remember that there's 3% of the two vaccine cohort who didn't respond to that, and 7% of the one vaccine cohort who didn't respond. And so it's really important to just add increasing levels of protection around ourselves to ensure that we don't get infected, and therefore also ensure ourselves we don't infect anyone else. Another thing that's important to recognize historically is that healthcare workers across the world who are exposed at work and come down with the disease end up having about a twofold increase in severe complications and mortality compared to the general population. I don't know why that is. I speculate that that might be due to the high viral load that healthcare workers are exposed to from the sickest of the sick when they come to the hospital for care. So, vaccines in and of themselves are a huge foundational part of our protection, but it's not the only part. And we can't forget the value of other protective measures, especially respiratory precautions. And because this is an airborne disease, using N95s or equivalent, eye protection, gloves, hand hygiene, et cetera, are all really, really important here. In fact, I think, we exist in a new era. COVID really changed, in my mind, the way that I think about my own protection. In fact, I think COVID certainly pushed us, but even since COVID, I've been a lot more thoughtful personally about what I'm doing to protect myself around patients with infectious respiratory symptoms. In an era of COVID, influenza, RSV, other respiratory diseases, I think we've got to start assuming this level of protection across the board, because there's even other things out there that could be causing these things like TB, other pulmonary infectious diseases that we've got to be thoughtful of. And I think this package of protection needs to become just as familiar as other packages of protections that we would never enter in high-risk zones without assuming, like our fire gear, for instance, when entering a risky or fire-based setting. So this package here needs to start becoming our new normal. But the good news is that if we assume this package of protection for patients, we end up protecting ourselves from all of these diseases we've talked about, especially measles, which is the focus of today's lecture. There's also patient protective equipment, so other ways to cut down on spread, masking the patient with a well-fitted surgical mask. I understand that some patients may have mental status changes, they may be hostile to the idea, but doing our best to do that is important. And then HEPA filters, whenever you're actively managing a person's airway who has any concern for a respiratory infection, using a HEPA filter is helpful. And that gets us to the very last bit here. And Eric, do you want to take over from this point on?
Yes, we can do that. So when you do encounter your suspected measles patient, or if you are transferring a patient who has a diagnosis of measles, we're going to want to know about that patient as soon as humanly possible. And the reason for that is there's a lot of things that need to happen on the hospital side to make sure that we prevent any unnecessary contact with that patient. Similar to what happened during COVID, we'll ask for a heads up as soon as you can. And this is really essential. The 1 minute out is not a great time. 10 minutes at least, and the further ahead you can get it, the better. And the reason being is what we'll want to be able to end up doing with these patients is we want to be able to put them in a negative pressure room. And when we're not in a pandemic, those negative pressure rooms may be occupied by other patients and other things. So we do need to start moving patients around before you get here. The other piece for us to understand is that we'll also want this patient to be housed in your ambulance until such time as we are able to get these things set up. But for us, it's specifically calling Remus, letting them know that you have a measles patient, so they understand that what their process is that they have to start. Other hospitals will have a different mechanism that they'll want to use for that. So you'll want to make sure if you are transferring to other hospitals that you get in touch with their staff to find out what the best process is to notify them. So if you do bring the patient here, we will probably use our CAPE system, which is this transfer module to bring the patient inside and move them from room to room if it's available. If not, we will ensure that the staff will give you guidance. Likely, K2 is our critical care room that does have a negative pressure system built into it and is going to be a more permanent one. But we'll ultimately advise you to which way to go. If your patient is definitely not clinically stable, you will be coming inside almost immediately. They'll take you to either the critical care room or they'll take you to a negative pressure room that's already been set up for that. But ultimately, our goal is to limit the spread as much as humanly possible. And by masking the patient, using the HEPA filters and everything, you can prevent a lot of disease transmission.
So, we spent a lot of time trying to understand more about the post transfer of care activities. I think it's fair to say that many of the resources are more geared toward hospitals. But we do want to acknowledge that there's some work that can help, some pre-event work that can help understand what the best way to disinfect and eliminate the potential for disease spread through exposure to your ambulances. Now, ultimately, all of your agencies have policies. Those policies really were probably robustified in the context of COVID, but it's worth taking a look at those now because COVID and measles are both airborne, but they're different enough that another redo of that policy is probably worthwhile. What we know is that it's useful to disinfect surfaces, especially high-touch surfaces, with a virucidal wipe. We use a gray top disinfectant wipe. You wet the surface with that wipe, and then you allow a minimum of 3 minutes for that to dry before contacting it again. I thought, I was looking historically to see if there was recommendations from anyone who's recently suffered an outbreak. And in fact, New York has a recommendation, and this QR code links to that. And the New York City authorities I think, took a really interesting stance in which they said either take your ambulance out of service for 2 hours to allow the particulate matter to fall and then decontaminate the interior surfaces, or talk to your vehicle manufacturer to determine the vehicle passenger compartment air changes per hour that allow for a 99.9% removal of airborne contaminants to establish a safe time period for reintroduction of the vehicle in less than 2 hours. That's a direct quote from their guideline. Now, the interesting thing is that that 2 hour mark is taken from hospital practices and rooms and non-ventilated environments in particular. And I don't know that it completely translates to our practice, in part because we have air exchangers in the ambulance, but also we open to the outside world when we open the doors. And so the air exchange rate through the back of an ambulance compartment, the driver section of an ambulance compartment is very differently. So I think the bottom line is you could follow that New York recommendation, although I think that's highly conservative. And it's probably worthwhile re-evaluating your own internal policies for this and having conversations with your ambulance vehicle manufacturer to discuss turnover times and what your circulation rates are that give you a better understanding about a more aggressive turnover time. That 2 hour period, again, that comes from hospital and non-hospital indoor experiences, and so I think that is too much. Eric, anything to add about that?
No, I think the major factor here is that a lot of ambulance companies and departments did a lot of research into how much air exchange they did have for their systems, and it is important to know how fast your trucks can turn over for this. The good news is we haven't had a case of measles. We haven't seen one for a while, but it is important to realize that measles it is a very strong virus and it lives for a long time, and that some sort of process will need to be followed to keep those trucks from spreading them themselves.
So I think that wraps it up, and it looks like we're almost on time here, Eric, which is awesome. So I
Fair
think
for
in
us.
summary, highly infectious, highly transmissible, high case fatality rate, preventable through high vaccination rates, but in the context of low vaccination, disease spread is very likely. The 24-25 measles outbreak is currently the second worst in the US by numbers, but the overall numbers, but that one outbreak in Texas, Oklahoma, New Mexico, and Kansas is the largest single event since 2000. And then we've also seen in that the first deaths in over a decade. High clinical suspicion and airborne precautions are essential for protection. Treatment's largely supportive. And then communication with hospitals can be really helpful. And just remember that quote we started this whole thing out: fate favors the prepared. It's not too soon to start those conversations. In fact, here locally, we've started having some of those conversations that I hope will lead us all to be better prepared moving forward. Eric, I saw a hand go up and down, and recognizing that we're in this model of the webinar, I don't know that we can unmute someone, but I wonder if there's a corresponding question that I can't see in the chat function.
Well, I'm looking in the let's see. I got a question from Tim Woodworth. If I am gowned, masked, and all PPE and pulled into the ER, do we go into the facility?
Yeah, great question. So the answer to that, Tim, is it's going to depend a little bit on how prepared that facility is. So, and we've also got the clinical condition of the patient to balance out. So if the patient is clinically stable, meaning we have some time, it might be helpful for heads up time for the ER and to coordinate that transition of care with the emergency department, in part because, we don't know exactly you may not know what room the patient's going to. You might have to transit by an immunocompromised person who's in the hallway or something like that. And just giving the ER a little bit of time to both identify the most appropriate location in their facility to bring the patient and also wayfind and clear the way for that patient to just ensure the most vulnerable are not anywhere close to that patient as they go through, all could be helpful. So the answer to your question is, it's awesome that you're gowned, you're gloved, you're got iPro, and you've got an N95 on, but we're also got to make sure that the patient and other patients in the facility don't get co-infected. And so a little bit of time on the heads up to allow the ED to do that, and then they will guide you to where you need to go after that becomes perhaps one of the best options we have available. Now, if your patient is sick, identifying that as you're doing your call-in becomes helpful, and the ED should identify where to go as promptly as possible and then transit there to transition care and do all of that stuff faster in the context of a clinically ill patient. I hope that answers your question, Tim.
We also had a question of what is the current Maine or U.S. policy regarding vaccinations for measles?
Yeah, so one of the ways that the U.S. public health system made such big inroads historically was to create policies at state levels that require vaccination um, before entry into public school systems. So it's very common to require proof of vaccination prior to entering school or to have a documented rationale why the child did not have vaccination. There can be lots of different reasons. There can be medical reasons, there can be personal reasons, there can be religious reasons. All of those reasons are valid. So those policies remain. That's not maybe exactly the same across all states, but it's fairly similar across most states. And so most states do have a required level of vaccinations that a person either has to achieve to gain or to give a reason why they shouldn't have it before they enter into school. Um, and that's true for lots of different schools. So, for instance, I had to do the same thing for my daughter when she entered into college. I had to prove all her vaccinations. When I went to med school, I had to prove all my vaccinations. In fact, I even had to be titered and get new vaccinations when I went to med school, just to cut down on the risk of Hep B. And it's fair to say that everyone on this call who is a licensed EMS clinician and therefore went through a training center probably had a similar experience, especially if they went through a training center based in Maine, because the same experiences occurred. So many of us have been vaccinated. Many of us have been vaccinated with 2 doses of the vaccine. Some of us may have only received 1 dose of the vaccine because we aged out before that second recommended dose occurred. But it's true that it's fair to say that that's the common way that vaccination has been achieved. Now, in the state of Maine, we have data to suggest that a very large portion of our population is vaccinated against measles. I think that number is in excess of 90%. It might even be closer to 95%. That's not true across the entirety of the US. We happen to be on the higher end of that vaccination rate, which does hopefully give us some protection. Because remember that for every person who's vaccinated and can thwart the spread of disease, it cuts down on the risk of the disease taking off like wildfire. And with that R naught of 18, if left unchecked, it just measles really starts to the incidence starts to climb exponentially over time. Hope that answered the question folks have. Anything else there, Eric?
Yep. If we go to we have a question about, are we going to start triaging at the dispatch level again? Travel known, exposure symptoms. I assume that would be when if we did have a notification of pandemic.
Yeah, great question. We'll have to see if that plays out. In the experience with COVID, we had very, very discrete geographic locations we were concerned about. In the Ebola events that we dealt with in the 2014 timeframe, we also had fairly discrete geographic exposures. It's a little bit harder with measles because, as you saw with that map that I showed, measles is kind of all over Asia and over Africa. Not to say that it it may still come up. I don't know that we're there yet, but it might be something we need to enact if we start seeing high case numbers. Again, we're lucky right now because we do not have any active cases. There have been a couple workups that have occurred in the state of Maine, but none of them have culminated with positive measles testing. So another reason for this lecture is it gives us time to all think about this collectively, prepare, get ready, etc. But right now, we haven't gotten to a point where we're ready to turn on EMD screening just yet.
We did have a question about the current recommendation for adult vaccination update, age, number of times. Someone was nice enough to provide the adult immunization schedule from the CDC for them.
You want to review that?
Let's see.
While you're pulling that up, Eric, I'm going to hover over this slide. This gives you a couple more of the references that we used, including a really nice fact sheet from the American College of Emergency Physicians. The next one is the CDC measles outbreak page. The Maine EMS Measles Clinical Bulletin, which was released earlier in March. There's an interesting couple educational things that Eric and I stumbled onto. There's a wiki lecture on measles, which I think is interesting, at least has some interesting pictures. There's a good osmosis video on measles, which is linked there in the middle. And then I mentioned a New England Journal of Medicine article that's a really nice summary article of measles that was published in 2019 around the time of that New York City outbreak. And I think it's still very clinically relevant. So I'll leave this on as Eric's um, walking us through the adult immunization schedule.
So ultimately, it does say that it's pretty much the same routine vaccinations of the as the 1 or 2 doses. If they don't test for it, they should have another dose.
I mean, if they don't have active titers against measles.
If they don't have the titers, yes.
Yeah.
They should have that. There was also a question about travel. And Joe was nice enough to throw some stuff up in the chat about the MMR recommendations. If people should, if they frequent, do you think someone who has travels a lot should get tested to see if they are still immune?
Yeah, great question. So if you hover over that CDC's measles outbreak page, on that page will be a link to other resources. And there are other resources for travelers actually that you can find in there. Bottom line, I think it depends, right? If you're going to the UK, maybe not. If you're going back and forth to Switzerland, first of all, good for you. But there's not a lot of endemic measles in Europe right now. If you're regularly going to countries where there is endemic measles, then it wouldn't be a bad idea to review that material. You can also ask your primary care physician to run titers to make sure you were a responder to your vaccination. And that is a way to confirm that you have been protected. And then I think it just comes down to being safe and cognizant while you're traveling and being thoughtful about avoiding folks with obvious symptomatology. But yes, you can get titered if you want to. And there are other resources on that page that I mentioned.
And I believe that concludes the list of questions.
Well, folks, really want to thank you all for coming today. We've really appreciated this venue and really enjoyed getting together with everyone and having a chance to dialogue. Even though it's in this forum and it might feel a little bit one-sided, we're really impressed with the engagement around this, and your words of encouragement after the fact have been really meaningful. So thank you. Also, thanks to Joe Minicello, who Eric referenced for this idea. We are right now at month 11 of this idea, and it's been really neat to see it all play out. So, Joe, thank you again for that. If you don't mind spending a few minutes hovering over this and giving us feedback, we do take your feedback quite seriously. We want to make sure these things are good for you, they're meaningful for you, that we're hitting the right information, tone, etc. So please give us a little bit of feedback. Another quick update is that we are going to celebrate our 1 year anniversary of this program during EMS week. So the week of May 18th to 24th, we're going to have 2 of these lectures. The first of which is going to be given by Dr. Jack Lewis, which is very appropriate since he's the one who kicked us off a year ago with his airway lecture. That's going to be on Monday of EMS week at 3 p.m. And the second one, Dr. Mike Bohansky is going to give. Jack's going to talk about handoff of the medical patient, and Mike's going to talk about ballistics and wound patterns for EMS. So we're excited to have those and hope to see you at those. And between now and then, we look forward to interacting with you, interfacing with you. For any questions, concerns, please reach out to us. We really, again, appreciate you being here. Thank you very much, and have a great rest of your day.
Thank you, everyone. Great to see you all.